I believe that dental schools are teaching us the wrong way to prep teeth for crowns. So in dental school, I was taught to break the contacts and then do occlusal reduction, axial reduction, and then once all the tooth was prepped, now we're gonna go do the margin at the end. And I found that to be very difficult to do. And so this way of going and just prepping the gingival margin last, I think is the most difficult way to prep a good margin on the tooth. So in my technique, we do that first. We actually prep the gingival margin right off the bat. Well, it's the second step actually. Right off the bat, we're gonna prep it. It is way easier to prep the gingival margin on a crown prep while the rest of the hard structure of the tooth is still in place. We've had 30 years of a pretty good thing in dentistry. And I think it's time that we have to step up to the plate and kind of do our job. And I think this picture on the screen kind of illustrates this. This is a screenshot of a dental technician here at the laboratory measuring the reduction that's been done for an Emax crown on a molar and sent in by a dentist. And you can see that the laboratory technician can simply click on the prep tooth and the opposing tooth. And when they click on these two spots, it tells them that there's 0.85 millimeters of reduction. Now, as you'll see in a minute, we need a minimum of 1 millimeter of reduction for Emax lithium disilicate on a molar, and preferably more. So with this minimum of 1 millimeter, the lab now has to call the dentist and say, hey, we don't have enough reduction on this tooth for an Emax restoration. Now, for the last 30 or 40 years, it was kind of a he said, she said, where the lab technician would say, hey, I don't think you reduced enough on this tooth. And you'd be all, well, I was there and I'm pretty sure I reduced enough. And since we write checks and give them to the technicians, the argument would kind of end there. They wouldn't give us too much pushback. But for the first time ever, for the last 5 years or so, dental laboratories have jumped ahead of dentists in terms of technology. And there's way more technology now in the average dental laboratory than there is in the average dental practice. And as a result, because of the embrace of CAD/CAM by laboratories, it's very easy for them, whether we send a digital impression or a traditional polyvinyl or polyether impression, for them to pour up the stone models, scan it, and then do exactly what you see here, which is click in between our prep and our opposing tooth and see to the 100th of a millimeter how much we reduced. There's no more he said, she said. We've been caught red-handed under reducing. And they'll be happy to send us a screenshot to let us know that here's what I'm seeing here. So for this case, we're gonna prep tooth number 9 using this technique. And tooth number 9 is an endodontically treated tooth with some old failing composites interproximally. So we're gonna go ahead and prep this for a crown. So step 1 of the reverse preparation technique, like most other crown prep techniques, is the break to contacts. So again, I'm just gonna use a 56 burr here. All we're trying to do is create some space between the prep tooth and the adjacent tooth, because I'm gonna slip a little retraction cord in here as soon as I do this. So here we are putting in a 00 cord. This is an UltraPack cord from Ultradent, and I'm just flossing it into place like it was dental floss, and then leaving a little excess on the facial so I can pack that down into that facial sulcus. Now this cord hasn't been soaked in anything. There's no epinephrine or anything in any of the strands, so it's a totally plain cord. And the reason for that is it's going to be in place for almost an hour. So this cord's going to be in place during the impression, during the fabrication of the temporary. We're going to cut the two ends of it on the lingual so they're going to get packed flush. They're not going to overlap each other. We want to leave room in the sulcus for our second top cord. So here we go. I said we were going to be doing it early, and very early on we're prepping the margin with that 801-021 burr. So now that we put that cord in, I've retracted that gingiva 0.5 millimeter. And so now I'm just following the outline of the gingiva with this round burr. And again, this is the easiest burr to cut with because it gets more stable the more you use it as it sinks into the tooth. I told you with my below average left hand, I should have nicked the gingiva at least 35 times over the last 15 years of this technique. I've never touched the gingiva once. It boggles the mind. I've made every other mistake you can make, but I've never touched the gingiva because as you cut with this round burr, it settles into this C-shaped groove that it's cutting into the tooth. And it's a self-limiting depth cut because the shank of the burr keeps it from going too deep. And so what we've managed to prep into the tooth is basically a perfect half circle because half of the burr was in the tooth as we were prepping it. And so that half circle that we've prepared into the gingival third of the tooth, that's going to act as our gingival third depth cut. making sure that we don't have any fake looking crowns. I mean, if you just glance at tooth number 8 now, you can see how flat that gingival third is on that natural tooth. And we formed our margin because we now have this half circle or this C-shaped depth cut in the tooth. And by the time we go in and remove the top half of that C, when we do the axial reduction, we're going to end up with like a quarter C shape, which is kind of the perfect medium margin. And that's the way we want to do it. So in this animation, it shows as we go back and forth and work our way kind of towards that free margin of the gingiva, which again has been retracted by 0.5 millimeter by the bottom chord. As we go back and forth, it becomes easier to cut with, and this red circle represents the 180 degrees that we have cut, that C shape that we have in there, which is going to end up being the perfect margin when it's all said and done. We do that on the lingual as well. This is the incisal edge reduction. Again, this all depends on what material you were using. You could go as conservative as 0.6 of a millimeter for a zirconia material up here, or 1 millimeter for lithium disilicate. We're actually doing 2 millimeters because this was a kind of a standard prep technique for bilayered restorations back in the day when we were doing this, and a lot more PFMs being done. So those depth cuts are done. So now I know how much I have to reduce there. So we've got our gingival third depth cut. We've got our incisal third depth cut. Now I need one more depth cut, my axial depth cut. And this one moved over the years, and it moved closer and closer to the incisal edge because this is what I need to do to get rid of my Bucky Beaver preps. So here's a great look at what this depth cut actually looks like. So start up the handpiece, boom, push it down, it seats, and it won't go any farther. There we go. So that's how quick these depth cuts are, and it was a great look at it in cross section, seeing it done. Actually now, I put that depth cut, that 1.5 millimeter axial depth cut you just saw demonstrated, I put that a little bit closer to the incisal edge. I put it literally just below where my incisal edge depth cuts are, just to make sure that I can't have a Bucky Beaver prep, because I have to reduce down to where that depth cut is. It's impossible to have a Bucky Beaver prep when you put that depth cut right where it is. Now basically we've got all the depth cuts where they need to be, and it's just time to blend all of these. And so even if it seemed like we took a little extra time, you know, on the front end of things, putting these depth cuts in, this is where you're really free to fly because it's just kind of a race against time here. Just grab that 856.025 and start reducing. It's a lot like having Waze or a GPS unit on your phone. You know when you're done now based on the depth cuts. You know, before I would just be prepping and prepping and prepping and wondering if I'm done. Yeah, I think I'm done. My hands get a little tired. I think I'm getting closer to getting done. Now I know exactly when I'm done, when I've reached my destination. I wish the handpiece would say,
"You've reached your destination,"
when you finish the prep and all the depth cuts are gone, but it really does feel kind of like a guided technique in that sense. Here's the 856.016 burr. That's the little brother of that other one. See, we can hold that vertically and take it in between that tooth and the PFM next to it we don't want to hit. We can take that on the mesial aspect of tooth number 9, and we can create that same kind of vertical wall down to the level of the gingiva without hitting that natural tooth, tooth number 8 next to it. And if we took that other burr, the 856.025 in there right now, we'd have to tip it so far over that we would end up with one of those TP preps. And that's how those teeth tend to get over prepped in the incisal third, is by taking too large of a burr and taking it in between, taking it in approximately too quickly. So we use that little one first, and then we finish up anything we need to do with the 856.025, blending those depth cuts. Step 7 is the lingual reduction. I'll usually mark this with a piece of articulating tape, and wherever that lower anterior tooth is hitting. If I'm doing zirconia, I'll put a 0.6 of a millimeter depth cut right through that blue mark. If it's Emax, I'll put a 1 millimeter one. And then I'll just use this 379.023 burr to make sure that depth cut disappears. I prep all that away, and now I know I've got enough room for my lower anterior tooth and enough strength for my material. And then I just use the football burr to blend that depth cut with the rest of the lingual surface so that it's concave. So after that's done, the prep is almost essentially done. We have one more step after we pack this cord. This is the top cord in this technique, a size 2 cord. It's actually a 2E cord from Ultradent, and the E stands for epinephrine, and I started using an epicord like this when I heard Gordon Christensen talk about using it. Oh, this is probably 15 years ago. And I said, I heard they weren't safe. And he said, well, my rationale is I use an epicord on any patient who can tolerate epinephrine in the local anesthetic injection. And if they can't, I don't use an epicord. I use a plain cord. And, you know, in my whatever, he said, 40 years of being a prosthodontist at the time, it's working very well. And so I just kind of adopted that same philosophy of do what Gordon does. And again, my goal here is to not only reduce enough for the technicians, but give them literally the best impression that I'm capable of doing, because I know they're judging me hard, not only on my reduction, but on my impressions as well. So if I can put a 2-chord technique and then have the top chord have some epi in it so that we don't have any bleeding, I'm going to do that. In fact, we'll do one more thing. We have a 3-part approach to taking great impressions, none of them which have to do with skill. The water's now turned off. I have my 856.025 burr spinning at 1,000 RPMs, and I'm starting on the lingual and going around and smoothing my margins. I'm looking at this at 5x through my loops, just going around on the margins, smoothing out all the chips that I know are there, but I can't see that they're there. You just got to trust it. It's like, I don't know, it's like Santa Claus or anything else that you have to believe it even if you can't see it. I think that was a line from the Santa Claus movie. And trust me, they're there. And if you want to go, you should go to your technician's office and see them blow up some of the margins. And if you're finishing your margins with a coarse diamond, you'll see it as well. So with the water off, so I can clearly see what I'm doing, we go around and finish that. And then we have one more step. There's a view of it from the incisal when the prep is all finished and we have enough reduction in the right places. The last thing we're going to do is place an anatomical Comprecap. This is from Coltine, and it's anatomical because it has cutouts for the papilla on the mesial and distal. So on an anterior tooth like this, the patient has to come out into protrusive and then bite together on this. They can't generate quite as much force. And I'm going to pause it here because I want you to look at blanching that we're getting above that. So look, for example, at the capillary bed or the gingiva above 6, 7, and 8. And notice that you still see that color there. And then look over on the right above 9, 10, and 11 where the patient's biting down. Biting down on these Comprecaps provides pressure to help drive out the blood out of the capillary bed. It's a temporary effect. We're going to have the patient close down on this for 8 to 10 minutes. And then when we come back, we're going to take off the Comprecap, admire the gingiva for half a second, pull that top cord, and then take our impression. Now we're pulling out this number 2 cord, and you can just see the lateral retraction that we have on that sulcus. That's what technicians crave. In fact, I'm starting to go clockwise around this preparation with the impression material, and you can already see how the material started to go counterclockwise because we moved the tissue laterally away from the tooth. And dentists seem to persist in this vision that you don't have to move the tissue away to be able to do that. Like I can find a super thin impression material, or I'll jam the tooth subgingivally and get it in there. It's not going to work, people. You have to create lateral retraction of the tissue away from the tooth to get a wide open sulcus to put your impression material into. The only way I have found to do that is either with the 2-chord technique or a diode laser. And I'm happy to use a diode laser on the posterior, but I'm not going to use a diode laser on the anterior. My assistant filled the double arch tray while I emptied the better part of a cartridge onto that one single prep. It's kind of a running joke I have with my assistant. Put it in the patient's mouth, close, and let them sit there for 5 minutes while that material sets. So that's the reverse preparation technique and all of its steps, ending with the impression being taken itself. And again, the key points of this that really make it different are prepping the gingival margin first and using that 801, 021 burr. I would encourage you to order some of those. Maybe order the 016, the 014, the 018, whatever kind of floats your boat. We don't really need the 021 all that much, but using that to prep the gingival margins while you still have the rest of the hard tooth structure is kind of the magical part of this, and it makes prepping an almost perfect margin. Simple, straightforward, and predictable. The depth cuts are a fantastic way to ensure that your technician has enough room to do whatever they need to do, and you'll start to notice that the crowns you get back from them are properly sized. They're the same size as the teeth they were replacing, and the aesthetics on those restorations is fantastic as well. You'll also have enough thickness in case you need to do an occlusal adjustment, and you should end up with a crown that lasts for many years, if not many decades. I remember the first time I tried this, and I looked down at the prep, and I couldn't believe it. It was the nicest margin I had prepped. And at the time I was 17 years into my career. And I handed the mirror to my assistant. I said, take a look at that. What do you think? And she looked at it. She said, wow. I said, yeah. She said, I can't believe you did that. And I was like, you don't get to say that. I can say that about myself. You don't get to say I can't believe, especially in front of the patient. Give me the mirror back. But she was right. I couldn't believe I had done it either.